Hi, I'm Walt Medlin, BonusLife.com. This is my personal website focused on education, and I want to talk about Medicare coverage for overweight and obesity. I'm not an insurance expert, but I want to at least diffuse some of the misconceptions about Medicare. And I've added in the upper left corner, since my introductory, butt-kicking 80-year-old is my goal for most of my patients, and that is, instead of saying the word quality of life, which is very vague. I think a lot of people have trouble having a vision of what quality of life overall is, but they certainly can name somebody who they know who's older and living life on their own terms and able to get up and go and do. And I think a lot of us who are affected by overweight and obesity get off of that pathway and feel like life has passed us by, and we're never really going to be doing what we want, even if we survive to an old age, that we're not going to be living life with minimal compromise. So in terms of Medicare, it's a very interesting issue right now. We do have bills going through the legislature in the Congress to cover things differently. There is coverage for weight management in Medicare, but it's a little goofy right now. So in terms of diet and counseling, if you have diabetes, you can see dietitians and get frequent visits. If you don't have diabetes, and I'm not perfectly sure on this, but I believe almost all of your coverage has to be done, all of your care has to be delivered by your primary doctor. And that can be a limit for a lot of people because their primary doctor is very busy and doesn't have a lot of time. Also, your primary doctor a lot of times doesn't have specialty training. Now, most docs have at least a good background, but the average medical student gets no more than an hour or two of nutritional training and specific training on obesity and overweight these days, even though we think about it all the time. Now, exercise is another thing where we know that exercise can help stabilize weight, and diet and exercise is what most people think of immediately when they think about losing weight, because they have lost some weight that way before. But with the disease of obesity, when people are more than 50 to 100 pounds overweight or beyond that, diet and exercise do not have a long-term effect. People will lose weight and then regain it. And most people who see me as a surgeon, including myself when I had surgery, I had lost weight several times but regained. And that is because diet and exercise don't impact, as I said in my earlier video, they don't really impact hunger. And our body signals very strongly to eat more, actually, as we exercise more and as we actually lose weight. Our body fights back against the perception that we're actually starving when in fact we're not usually. So exercise is not covered that well with Medicare unless you have another issue that's going to take you to a physical therapist. So you certainly, these are parts of being a butt-kicking 80-year-old. Having a healthy diet, having good regular exercise, maintaining your muscle strength and your muscle mass, not becoming frail, very important, but not very well covered. Medication at this point is not covered by Medicare hardly at all. Again, some medications for other conditions will have a side effect of having some weight loss, but strict weight loss medications are not actually covered currently under Medicare. They're actually excluded. This goes back from the days in the 60s and 70s when the only weight loss medications were basically drugs that were very easy to abuse. They're basically methamphetamine or speed related type drugs, and they did work well for weight loss, but they had way more side effects, and so they were basically excluded. Now, fast forward to 2019, we have a lot of medications that are actually pretty darn effective for suppressing appetite. They're not the dream medications yet that most people want. A lot of people who come to see me want to lose more than 10 or 20 pounds, and most medications, on average, that's what they give, is an extra 10 or 20 pounds. There are some people out there who lose more, but again, there are people who lose more in the short term, even with diet and exercise. Most of us have lost more in the short term, but they can be effective, and they really are useful. We, like I said, have legislation specifically going through the Treat and Reduce Obesity Act, and you can read more about that on Obesity Action Coalition's website, obesityaction.org. about hopefully that getting passed in the next year or two to give your doctor, your primary doctor, more options to prescribe medications. And there's several different types of medications that work in different ways. All of them have, like any medication, some pluses and minuses. Some people who shouldn't be taking a certain medication if they have other medical problems. So it's not a one-size-fits-all deal by any means. But that's the same way with my doc and my blood pressure. He's got a large toolbox of medications he can use, and we discuss what might work best for me, what might have side effects I don't want, and if we try something and it doesn't seem effective, then we've got other options. And so that's really the conversation you want to be able to have. First of all, with your primary care doctor, but honestly, I really think this is specialty care enough that most patients who are going to be on medications long term should be seeing a bariatric medicine or an obesity medicine specialist. And the Obesity Medicine Association website has a list of a lot of docs and practitioners who will provide that care as well. I think it's always good to have that in cooperation with your primary doctor, and that's a gray area that can go back and forth. Now, surgery, which is what I do for a living, and I'm a surgical patient. Surgery, you would not believe this, but it is incredibly well covered by Medicare. It doesn't mean we get paid a lot. Medicare doesn't pay a lot to doctors, but it pays hospital bills, and it pays for my professional fee. There are a couple of things that aren't paid for that most programs have a program fee for those things that they never get reimbursed for, and those are usually a few $100s, that program fee. So you will have out of pocket if you have Medicare. You will have the same out of pocket as if you have any other operation, also if you have deductibles. And some of this is a little over my head, but I hear so often with people on Medicare, they didn't even know they had coverage at all, when in fact they really do have very comprehensive surgical coverage. And that's for all the operations that we do that are surgery. So that's gastric sleeve or sleeve gastrectomy, gastric bypass, which we don't do many of, but there's good coverage, and duodenal switches, which our preferred operation is over gastric bypass. And I'll get into that on another video, but you can also just come see us one-on-one. You do not have to have your mind made up which operation you're going to have, and you probably shouldn't have your mind completely made up until you see a surgeon one-on-one to discuss your medical history. So, but know that surgery is very well covered, and it is the most effective option for long-term weight loss. Now, anybody who has surgery definitely does have to have dietary support, and we have a dietitian in our practice. Most practices do, or at their hospital in coordination. Almost everybody has an exercise plan that people follow because that is important. So it doesn't, you're not skipping these steps. This is not a cop-out. Medication is also something that we plan to use more with patients as coverage becomes available. Most people don't want to pay that much out of pocket in an ongoing long-term way, but you will find, if you have friends who have had surgery, a lot of them are going to be on a medication to help their operation work for best hunger control. Quickly, I just want to point out there are a few other non-operative interventions that are not covered by Medicare because they're labeled as experimental. They are somewhat new. You may hear about endoluminal sleeve gastroplasty, which is different from sleeve gastrectomy. It's a scope that goes through the mouth and basically tightens up the stomach. Still viewed as experimental. There's an Aspire Assist, which is a tube that helps take out some extra calories. It's not like bulimia. It's very responsible, but it's not covered for this indication. And then the balloons, the Orbera and the Reshape and the Obalon intragastric balloons that are placed non-invasively through the mouth and the stomach, those are not covered right now with Medicare as far as I know. For Medicare, there is a requirement that you have preparation time, so don't come in thinking you're out of a consult one day and surgery the next week. It takes about 90 days for the average patient to work through the preoperative counseling, and you can start that before you see us. So if you call and make an appointment for us in a couple of months, usually we're available before that, but if you call and make an appointment with us, you can go ahead and see your primary doctor and have a medical weight, a supervised medical visit where they measure your height and weight, they talk about your diet and exercise, you set some goals. You don't necessarily have to change major things, but you need to have these visits. So that's at least a basic intro. I do want to talk about disability and age. Those are not going to put people out of reach of having surgery, previous surgery and other illnesses, the same way we operate on people who've had heart attacks before. A lot of people have bad diabetes. People who've had open abdominal surgery, including having part of their colon out. A lot of people have had hernia repairs, hysterectomy, gallbladder, things like that. So don't feel like you're disqualified for any of these reasons. Now, we may sit down with you and talk about your one-on-one risk, and you may make a decision that you don't want to proceed, but almost all of our patients are able to have surgery with little incisions, just like with gallbladder surgery, laparoscopically, and we almost never have to make a big incision. Medicare does not require a referral from your primary doctor, so you can call us directly and come in and see us. We always want to cooperate with your primary doctor, but we don't need permission. All right, well, I'm Walter Medlin, BonusLife.com. Thank you very much.